Uh, we now invite Dr. Priya GOYAL. She will be presenting on accuracy of IOL power calculation in pediatric traumatic cataract.
A very good morning to the judges and to the audience. So I'll be presenting the paper on the topic of accuracy of IOL power calculation in pediatric traumatic cataract. Management of pediatric traumatic cataract is itself a very challenging task in terms of timing of the surgery, anterior segment and posterior segment associated trauma, inability to implant the IOL in the bag or in the eye altogether, and also the post-operative visual rehabilitation. So the main aspect or regarding the pediatric cataract management is basically the IOL power calculation and the post-operative prediction error. So basically, after trauma, there is a cornea damage in terms of corneal tear or the associated scar, and also there is excellent change, maybe immediately or maybe after the trauma, maybe few months later due to the asymmetric eyeball growth. And both these are the most important factors which affect the IOL power calculation. And any errors in the measurement of these factors can lead to high prediction errors, which can in turn cause embryogenic anisometropia and complicated visual rehabilitation postoperatively. However, we have a lot of evidence in the literature regarding the visual outcomes following the pediatric traumatic cataract management and also the factors affecting the poor vision. But the accuracy of IOL power calculation has not been studied in any papers. Most of the studies have excluded the history of trauma. That's why it becomes more important to study. So the aim of the study was to evaluate the absolute prediction error in pediatric traumatic cataract and the factors affecting it, and secondarily to compare the prediction error using keratometry of the fellow eye and also the standard K value in the eyes with the corneal scar. It was a retrospective study which was conducted from February 2019 to March 2022 with a duration of 2 years, and the data was collected from the EMR system. The inclusion criteria was age less than or equal to 16 years, with the eyes having unilateral traumatic cataract where IOL implantation was done at the study center. Any other cause of cataract apart from the trauma was excluded, and any pre-existing ocular problem or associated posterior segment involvement or glaucoma was excluded. And also, if after the cataract surgery eye was left aphakic, that was also excluded. Any children with incomplete data or loss to follow were also excluded. The data was collected in terms of the details of the surgery and the details of the injury and all the examination details. IOL power calculation method was either used optical method in children who were cooperative, and in non-cooperative children, contact ultrasound biometry with handheld keratometer was done under general anesthesia. IOL power calculation formula which was used was SRK-T in children less than 2 years of age and also in axial length less than 22 millimeters, and rest of them were SRK2 was used. Age specific undercorrection using NID's formula was done. The target refraction was calculated by deducting the implanted IOL power from the calculated IOL power, and the final refractive error was measured at 6 weeks after the cataract surgery, only after performing the suture removal. The formula which was used was absolute prediction error, was target refraction minus the observed refraction. Also, in eyes with the corneal scar, just to see the effect of corneal presence of scar affecting the prediction error, we calculated a simulated prediction error by using the average K of the fellow eye and also the standard K value of the 44 diopters. And then this simulated prediction error was compared with the absolute prediction error when keratometry of the affected eye was used. The data analysis. So prediction error was categorized into 3 categories, and all these factors, including the parametric and the non-parametric data of the affected eye at different categories of the prediction error were compared, and appropriate statistical tests were applied. So out of the whole data, 132 children were seen to have unilateral pediatric traumatic cataract, but the children who met the inclusion criteria were only 50, which were included for the final analysis. The mean age at surgery was 9.47 years, and only 2 children were having age less than 2 years, and there was a male preponderance. 38 eyes had worse visual acuity worse than 6/60. 22 eyes were having open globe injuries and 28 were having closed globe injuries. Primary globe repair was required in 15 children. The presence of scar was seen in 34 eyes, and out of which the visual axis was involved in only 16 eyes. Cataract surgery was performed within 6 weeks of trauma or the repair, and rest were having surgery later on. Primary IOL implantation was done in 40 eyes, and secondary IOL implantation was done in 10 eyes with an average average duration of 4.3 months after the cataract surgery. PPC and vitrectomy was required as per the age less than 6 years, or if there was a pre-existing defect or the capsular plaque at the PC. The prediction error values were ranging from plus 3.5 diopters to minus 9 diopters with a mean value of 1.63. There was no prediction error seen in 5 eyes, and highest prediction error was seen in youngest children with the age of 2 years. And there was overestimation of the IOL power calculation in 35 eyes with a mean value of 1.6 diopters, and underestimation was seen in 10 eyes with a mean value of 1.07. There was no statistically significant difference between the mean axial length of the affected eye and the fellow eye. Also, not significant difference between the average K of the two eyes. The following factors were studied to see if there is an effect on the prediction error. So there was no significant p-value seen in age, status of primary repair, type of IOL implantation, or the position of IOL, or whether AV or PPC done or not, or due to the method of axial length measurement, or the presence of corneal scar, or the keratometry values. The only significant p-value was found in the preoperative axial length, and we can see in this scatter plot graph that as there is a smaller axial length, there was a higher prediction error seen. Also, in the eyes with the corneal scar, we measured the absolute prediction error of the affected eye, and we compared it with the simulated prediction error of the fellow eye as well as the standard K values. We could not find any statistically significant difference just on the basis of presence of scar. But however, when the scar was involving the central visual axis, then we could see that high prediction error was seen with the values of keratometry of standard 44 diopters, and when compared with the simulated prediction error using the fellow eye, there was no significant difference. There were similar values.
Can you conclude, because the time?
Yes, sir. So the range of the prediction error which was seen in our study was similar to the other studies also in the literature. And also there has been evidence in the literature that less than 2 years of children have higher prediction errors ranging from 0 to 21 diopters, which was seen in our study as well. And most of them have correlated it with the shorter axial length, which was seen in our study as well. So the possible reasons which we could find was basically mainly because of the errors in the measurement of axial length, because we used contact biometry instead of immersion technique, and immersion technique causes measurement of axial length little higher than the contact method. So there will be probably there was an overestimation in our study because of that. So the strengths of our study was there is no similar study, and this is the only study to exclusively evaluate the prediction error in traumatic pediatric cataract. Most of the studies have excluded it. The main limitation of the study is basically its retrospective design. There was few of data which was lost to follow-up, and we could not find the complete data. Multiple examiners performing the biometry and the multiple surgeons were involved. However, we could not adjust these factors to analyze their effect on prediction error. So to conclude, the current study analyzed the prediction error exclusively in pediatric traumatic cataract surgery with IOL implantation. We found that the absolute prediction error in such cases were higher than the reported in literature for non-traumatic pediatric cataracts within the same age group. The axial length of the affected eye was the only parameter significantly seen to affect the prediction error. And finally, in cases where corneal scar precludes the keratometry, probably the fellow eye keratometry can be used. Thank you.
Thank you. Actually, during my fellowship, I had presented a similar paper, but it was not on. We did not include a traumatic cataract. So, as regards the results, were very similar as far as the age and the axial length. With the lesser the axial length, lesser the age, the prediction error is much more. So, I mean, results are quite similar. Did you? I mean, try to analyze the absolute prediction error with the duration of between trauma and surgery?
Yes, sir. It was not significant. However, the longer the duration, we could see higher the prediction errors, but the difference was not statistically significant.
All your cases, traumatic cataract had a corneal scar.
No, ma'am. Only 35 eyes.
So, so
we have overall studied the prediction error in all the 50 children, which was the sample. And also, especially in the eyes with the corneal scar, we have separately analyzed them. So we have calculated simulated prediction error only for those eyes.
Yeah, you have to separate those.
Yes.
And you did a contact biometry in all these cases. That is
only
not
in the
good idea.
uncooperative children. Thank you.
Thank you.